So what are the typical features? Usually it's in smokers. Most people with chronic lung disease have a tobacco history or secondhand smoke history, but not everyone. It usually presents in the 5th decade unless you have a predisposing illness, bronchiectasis, chronic infection, or alpha-1 deficiency. I've seen emphysema in patients as early as 28 years old with those deficiencies. It's typically slowly progressive. It's not a disease where you wake up with a cough and then 4 or 5 weeks later you're bedridden. It's usually something that every year takes a little more out of you. And it's interesting, at the VA practice, taking care of a mostly male population there, men handle that change differently than women. With women, when they notice that they have shortness of breath with activity, they tend to go to a doctor. You guys are really good about primary care. What do guys do? They buy a riding mower because it's too hard to push a lawnmower. They get their wife to take out the trash cans because it's really hard to get up the lane after wheeling down the trash cans. Men tend to minimize the symptoms and they change their behavior rather than get it treated. The problem we have with the physicians, some of you have voiced some negative comments about doctors. We're clearly not a perfect group. The problem with physicians is they think shortness of breath is going to be asthma or a cold. And they usually don't think beyond that. How long have you had it? How is it affecting you? And what risk do you have for any of those other diseases? So I'm teaching my students, it's not just what the patient says. You have to know how to ask the right questions. So if you say, how you doing today, and the patient says, fine, you shouldn't write down, patient has no complaints, because you haven't asked the right question. So we've talked about the lungs, that's what I do. But what else do we know about COPD? Any of these illnesses of the lung, they're chronic inflammatory illnesses of the lung. They affect the whole body. We're not just a piece of lung in a pan. We're an integrated unit. We have a heart, we have a brain, we have kidneys. And unfortunately, respiratory diseases affect all of those. There is an increased risk of coronary artery disease in people with chronic lung disease. And that's totally independent of whether they're smokers or not. And it has to do with the same inflammatory injury pattern that's affecting the lung causes atherosclerosis in the blood vessels. It also affects the peripheral vascular tree. And there are groups now doing research looking at something called Doppler signals in the peripheral vessels, in the arm, in the leg, or up in the neck, as a way of predicting who's getting progressive disease and who's not. Osteoporosis is not just in people using steroids, that's weakening of the bones. Obviously, postmenopausal women are predisposed to it, but McGuire VA was one of the early sites doing research in osteoporosis in men. Turns out men on steroids, men on opiates, like morphine, men with chronic lung disease, men with liver disease, have accelerated osteoporosis that's equal to that of women. It's just as damaging in the men as it is in women. With severe lung disease, you get a strain on the heart, and it's the right side of the heart that's affected. So I know you had Dr. Morris here not too long ago.
Yes, we did.
And he, of course, is my favorite cardiologist. I've known him since he was in training. And he always talks about the left side of the heart, the business part of the heart. That's the part of the heart that gets all the blood to your brain. I look at the right side of the heart. It's usually thin. It gets blood from the circulation back to the lungs to get oxygen. And when you have lung disease, that right heart gets big and swollen. And when it stops functioning, it can't get the flow from your legs back into your body, so your symptoms are swelling up the legs. How many of you have noticed at the end of the day your legs are really big? And then the first thing in the morning, the legs look a little bit better. That's related to the right heart function, and it's under a little more strain. It's called poor pulmonology. That it just means enlargement of the heart due to the lung. Cachexia. We're going to talk about how the disease presents itself. Some people with chronic lung disease put on weight. Many people become frail and they lose weight. And they just become emaciated. They become very thin because the calories that they're taking in aren't enough to support the calories that they're burning through hard breathing. And then depression. This is a horrible, debilitating disease. and it can really affect your spirit. And all of us have been faced with challenges in our lives. Chronic lung disease is a very difficult situation. So one of the things I ask my patients is, how are you doing physically? How are you doing symptom-wise? How are you doing spiritually? How are you feeling about your life? We had a lecture recently about advanced planning. It's really important when you have a chronic lung disease to establish what your goals of care are, what you're willing to endure, what your goals are for your own health. And then, God forbid, what would you do if things were to get worse? Now, do we have any guidelines? So in the old days, every doctor had their own recipe for how they were going to treat conditions. And then in the 80s, they came up with a term called evidence-based medicine. And what they said is, instead of us guessing how to treat patients, let's get a consensus from experts on what the best evidence is telling us how to manage heart disease, cholesterol, high blood pressure, whatever ails us. So for COPD, there was the National Heart, Lung, Blood Institute and the World Health Organization. They impaneled, honestly, a brilliant group of doctors who wrote a consensus article that's huge. It's like reading the yellow pages. But it came out in 2001 and was called the Global Initiative for Chronic Obstructive Lung Disease. How to recognize it, how to treat it, how to take care of it chronically, and what are the unusual options at the time. Now, the problem with a document like this is from the time they write it, the time it gets printed, to the time it gets disseminated to the public, the therapies have already changed. Medicine is that dynamic. So what they've done is something called an e-book. It's an electronic version, and it is updated every 3 years. And it was just updated at the beginning of this year. So the physicians can actually log on and see what the best practices are right now, and not rely on something that's 10 years old. Next slide. So they have some advice for us. And the first thing is how to assess and monitor for COPD. So the first thing is any patient with a chronic cough or sputum production and risk factors for COPD should be tested even if they don't have shortness of breath. And the gold standard test is spirometry. I know was it last year that Becky Alberti came by, or was it this year that you had lectures on spirometry?
It was last year. We had Becky Alberti.
Yeah. I worked with her years ago.
She's terrific.
Yeah.
She just did my PFTs last month.
So doctors need to know to look for it. We screen for high blood pressure. We screen for cholesterol. We screen for breast cancer and prostate cancer. Why aren't general doctors screening for chronic lung disease? It's just not part of their teaching. So our job is to try to educate our colleagues on having a low threshold for ordering, but it's really a gold standard test. Spirometry is the gold standard for measuring airway limitation, how much you get in, how well you blow out. It's also the gold standard for looking at all these other conditions you've been talking about, like fibrosis of the lung, or even dermatomyositis. Spirometry is the way you tell one type of pathology from the other. They define it based on the ratios of how much you can get in and how much you can blow out. We won't spend time on that today. So again, when should you suspect COPD? When should my students suspect it? The patient has a chronic cough, if they have exertional shortness of breath, if they have persistent symptoms that don't go away in a week or two, if they describe heaviness of the chest or air hunger. Those descriptors are very unique for lung disease compared to heart disease or other diseases. And if they have risk factors, and in my career it's mostly tobacco use, but I'm also looking at people who have dust exposures and other environmental exposures. So what about these gold criteria? Well, one thing is, it's in our best interest to look, because as the disease progresses, it has a very significant impact on health economics and quality of life. We see as the disease goes from mild to moderate to severe, more emergency room visits, more hospitalizations, more doctor visits, more home health supplies, so that the care of the patient escalates as the disease progresses. So it's in our best interest to try to find a drug. The difference between the disease we're talking about and just a viral syndrome is this is airway obstruction that doesn't get better. It tends to get worse over time or is fixed over time. And the party line about the medical therapies, everything from Primatene Mist 30 years ago to all these high-tech breathing devices you have now, is that they decrease symptoms, but they may not truly alter the disease. They make you feel better at the moment, but the COPD doesn't go away. And it's really important that you tell patients that, because often they're disappointed that they feel better with a breathing treatment, but not very long, and then they stop using it. Now this is what's new, that these newer medicines, these long-acting bronchodilators, long-acting muscarinics, that's a drug like Spiriva. I'm not supposed to do any industry endorsements, but I'm just going to throw names out for familiarity. Inhaled corticosteroids, that's drugs like fluticasone, Flovent. They have been shown over time to actually reduce the number of ER visits, reduce exacerbations, and improve compliance. And there are now at least 2 studies that show improved quality of life, improved exercise tolerance, and one that kind of suggests a better survival. So maybe these newer drugs are making a difference. Yes?
Is Symbicort in that group?
It is. I'm going to show you some pictures of that. So then, doctors don't really communicate very well with each other. You may have had that experience. Your specialist and your primary doctor are talking about different things. So this group recognized that, and they came up with a scoring system, having stage 1, 2, 3, and 4, going from the most mild of disease to very severe disease. And in the old days, it was based purely on the spirometry. Next slide. And it was really based on observations from 40 years ago. It's hard to believe it was this long ago. And this was done in Great Britain, where they were looking at the natural history of lung disease from age 25 to 75 and beyond. What they said was, in most people, if you look at the desired spirometry, as we age, we lose a little bit of lung function over time, from our 20s to our 50s to our 70s. And that's what these lungs represent. In most of us, the amount of lung volume that we lose is so inconsequential, we really don't notice it in our day-to-day activities. In people with chronic lung disease, especially smokers where it's accelerated lung disease, they have a dramatic drop that begins in their 30s or 40s and gets to a zone where they've lost so much lung function, they start to have symptoms in their 50s. They may have some exertional disability in their 60s. And if it's unchecked, leads to premature death in their 70s. And that was the lung disease, that was COPD in the 1970s. The other observation they had was if you were to take a smoker with lung disease and get them to quit smoking, and you still followed them every 3 years, the decline of lung function goes back to that of a non-smoker within a couple years of quitting smoking. I tell my patients that because I can't tell you how many have said, listen, doc, I already have the disease. Why should I quit smoking? It's valuable. It makes a difference. Excellent. So that was the slide I learned on. That was the slide they presented when I was in medical school. And then this study came out about 10 years later. And this was a real-life study. They were looking at a new therapy. And that study actually turned out not to be very helpful. But what was helpful is in the group that was studied, they said, well, let's just break them down based on their spirometry to see if that old Fletcher-Pato graph from 10 years ago really held up true. So they looked at the people in the study over 3 years, and then they said, were they the ones with the normal spirometry at the top, abnormal spirometry, or very, very severe spirometry? And this is looking at the percentage that were alive at 3 years. And obviously, more people with advanced lung disease die in 3 years than people without advanced lung disease. There have been many studies that have shown this. So the degree of obstruction that you have is somewhat predictive of the healthcare impact you're going to have. We use the term morbidity and mortality. Morbidity is the illnesses you have, mortality is premature death.